Okay, sir, we'll start the session, sir. Team 1,
Good
yours
evening.
first spotter. I would like to request ma'am Neela Bhattacharya ma'am and Veena Singh ma'am. I think Veena Singh ma'am is not there. Bhattacharya sir, you can lead the questions, sir, for the spotter one.
Yeah. So team 1, what is your diagnosis on seeing the spotter?
Ma'am, can we know the mode of injury burn? Otherwise, on inspection, we can see second-degree superficial burns over face, neck, and shoulder. There are trickling signs which might be suggestive of scald burn.
No. A trickling sign, which scald is going to produce such signs? So see the area which is burnt, and what do you think can be the etiological factor? There is a trickling of a dark brown fluid. Okay, I'll give you the answer. It is acid burns.
No answer.
No, not yet.
No, sir, because then the next question we cannot pass if they cannot
No,
make
it is to
the...
be passed to the team
No
2.
answer.
Yes.
Oh, sorry.
Yes,
Team
ma'am.
2, you can
Yes.
answer if you know the question.
Yes, sir. Sir, there's a facial burn. It looks like chemical burn injury. There's an involvement of the eye and also the forehead with superficial, second-degree superficial, and also third-degree superficial with involvement. And there is a presence of crust in the third facial. There's a presence of crust, and also there's involvement of nose, and there is a swelling of the lower lip.
Fine. So you diagnosed it as a chemical burn. So the next question will go back to team 1.
Yes, ma'am.
Yeah.
Team 1.
Yeah. So team 1, then now he said chemical burn. Can you now tell me what would the etiology be? What do you think it is? Is it an acid burn? Is it an alkali burn? Team 1.
Ma'am, it appears to be an acid burn.
Okay, acid burn. So what could be the acid?
Ma'am, brown discoloration can be due to nitric acid.
Actually, no. Nitric acid does not produce a... yeah, team B?
Yes, ma'am. Ma'am, there's a swelling and also there's a darkish brown discoloration. It could be sulfuric acid. It could be sulfuric acid, ma'am. H2SO4.
Yes, sulfuric acid. This now I'll tell you the history. It is vitriolage.
Yes.
So the common is sulfuric acid. Anything else? Seeing the burn, any other acid can you think of? Sulfuric acid has a slightly different. It will do one more thing.
It could be hydrochloric acid.
So these are the two acids. Yes, either hydrochloric or sulfuric acid is most likely this. So now team 1, you've got a person who's coming in with a chemical burn. Now tell me, what will you do and what steps are you going to take from step 1? This I will do. Please go on.
Yes, ma'am.
Team 1.
Initially, when we receive the patient in emergency, ma'am, we will look for airway, breathing and circulation, the GCS of the patient.
No, don't. Even before that. When you go to see the patient, what will you be sure about first? It's a chemical burn.
Yes, ma'am. Initially, the areas on which the vitriolage has been done, that areas we'll examine, and hemodynamic stability of the patient, and the substance. On taking the history, we'll evaluate regarding the substance, and then we will try to ensure that we remove the chemical substance as soon as possible by irrigation of the patient on the areas where he has been affected.
Okay. Team B, would you like to qualify it a little better? What will be the first step that you do when you go to examine a chemical burn?
Ma'am, the first step would be we will remove all the contact, the burn. We'll remove the cloths and all, and also we'll irrigate the wound with the plain water or the normal saline, and remove all the jewelers which come in contact with the skin.
Okay.
And also
So
irrigate the eyes, protect the eyes.
how the first step which you'll do is you'll protect yourself. That is the first thing that you should say. In a chemical burn, when you're going to touch the chemical, how do you know you're not going to get burnt? The first thing you will do is protect yourself. You wear gloves, you wear protective goggles, and then go and examine the burn. All right. Then all the ABC, etc. You read. Irrigation. How long are you planning to do irrigation in chemical burns?
Ma'am,
In this burn, how long will you irrigate?
ma'am, till the effluent is clear, ma'am.
Oh no. Are you meaning to say if you irrigate this brown structure, the brown structure will come off in your hands and you'll have a clean thing inside it?
Ma'am, we'll irrigate for at least 20 minutes.
This is team A, no? Team B?
Ma'am, we'll irrigate for approximately for 30 minutes to 45 minutes till the burning sensation goes off.
Till the burning sensation. Okay. Why do you say this is an acid burn? Why, from what are you saying that this is an acid burn and not an alkali burn? What is the difference in
Team A.
presentation?
Team A.
Team A?
Ma'am, acid usually produces a coagulative necrosis, causing the superficial second degree burns in which we can see in the patient, ma'am.
Plus charring of tissue can be seen
The
in acid.
crusting that is seen, ma'am. That stops as the coagulative necrosis, ma'am.
What is coagulative necrosis? What actually happens in coagulative necrosis?
Ma'am, the proteins are coagulated, ma'am,
Yes.
which creates the charred crusting, ma'am.
Okay. And what happens in alkali burn?
Ma'am, in alkali burns, there is a liquefactive necrosis which keeps on progressing deeper and deeper.
How is it visible? How do you know this is not an alkali burn? How does it look?
Ma'am, the crusting will not be as seen in this kind of patient, ma'am.
Team B? Team
Ma'am,
B?
in alkali burns, yes, ma'am. In the alkali burns, there will be the more of a destruction, and there is a saponification of fat, and the eye destruction will be more.
How will it look? Why is this not an alkali burn?
Ma'am, the structures are well preserved. There is charring. There is in first photo we can see that there is a layer of charred coagulated structure present. In acid burn, it will be more of liquefactive. There will be disfigurement.
Fine. We'll do the answer later. How does the burn in chemical? You're saying coagulative necrosis, liquefaction necrosis. What actually happens? What are the mechanism of a chemical? There is no heat, isn't it? Then
Yes.
what is the mechanism of the burn? How does it occur?
Ma'am, the protein coagulation occurs.
Like what chemical processes occur? Team B?
There is a denature of the proteins, a denature of the collagen, and the proteolytic degradation of the enzymes, and also, because of the reaction, there will be release of the keratinocytes and the granulocytes from the degraded epithelial cells, and this collagen and exothermic.
No, that does not occur.
And also
that does not occur at all at the mechanism level. Team A?
Ma'am, dehydration occurs. There is a
That is one way of doing is by desiccation. That is dehydration. Any others? Can you tell me?
And there is a exothermic reaction also.
No, exothermic, we'll come to that, but that is not a mechanism. So one is dehydration, then what else? I'll give you something. I'll say it something's oxidize. Then any other mechanism can you think of?
Neela ma'am, may I chip in for a single question?
Yes.
Yeah,
Please,
yeah.
please do.
Good afternoon, good afternoon. So my question to team A would be, which burn is more severe, the alkali or the acid burn,
Ma'am,
and
the
why?
alkali burn, because ma'am, in liquefactive necrosis, it keeps progressing deeper. Just in acidic burns, ma'am.
What is the term which is used for this type of liquefactive necrosis in alkali burns? Team B would like to answer.
Yes, ma'am.
When there is an alkali burn, there is a specific term which is used.
There is saponification of fat will be there, and
What's that? What's that?
emulsified saponification of fat. And
What is saponification? You need to explain to understand the mechanism of alkali burns.
Yeah, that is what mechanism they're not able to say. So I think we'll go to the next and answer this later on. Team 1, Team A.
Yes,
Why you said you will irrigate the chemical burn, isn't it?
yes, ma'am.
Now, in what sort of burns you cannot use water to irrigate? Can you tell me
Yes,
in what
ma'am.
burns
Ma'am,
you cannot use water?
in case of phosphorus burns, ma'am, we cannot use water as it ignites. And similarly, ma'am,
Phosphorus. Are you sure? Any other burns? Can you think about? Phosphorus is wrong anyway. Team B.
lime burns.
Why you should not use water in lime burns?
Lime burns, if you put water, there is exothermic reaction, ma'am, with water. So we
So
have to.
along with that is one. So how will? But then definitely you will use water. Then before using water, what will you do?
We will dust off the powder, ma'am, lime powder, so from the body.
Dust out all the lime powder, and then that is one. Then any other burns? In what
Ma'am,
burn water is contraindicated? You cannot use water in that burn.
yes, ma'am. Ma'am, with hot metallic metal, any metal with hot metal contactors,
Why hot metal?
we'll use oil.
sodium metal burn.
Yes, sodium metal,
Sodium
and
metal
then
burn. Sodium
any
metal.
other all elemental metals. Okay,
Yes,
so
ma'am.
you can. Why can't you use water?
Because it reacts with water only and causes an exothermic reaction, increases the burn.
No, I didn't hear you, doctor.
Ma'am, it reacts with water itself and it causes an exothermic reaction and the burn increases.
Okay. Only with water?
Also with air.
Yes,
Also
with air and water. So in those burns, what are you going to use then? How are you going to manage?
Ma'am, first we'll use the
Guys,
oil.
team A, please. In metallic burns, you cannot use air or water. Okay, you cannot subject the person to water. So what will you do to the burnt area? How are you going to manage?
Ma'am, first all the elemental contacts should be removed. It should be dusted. We can.
What are you going to first pour on the burn, doctor? Okay, you should immerse it in oil, all right? Then tell me, what else will you do?
Madam, sorry to interrupt.
Yeah.
Time is almost 12 minutes, ma'am. Yeah.
Time is all right, over?
Yeah.
Yeah, that's fine
You
then.
can answer the questions which were not answered by the teams.
Yeah, acid burns produce an HR and therefore it does not go deeper. Whereas alkali burns produce saponification and hydrolysis. So the burn goes on deep, the alkali goes on deeper and deeper and even up to bone. So that is the essence. So the alkali burn will be moist and white and some whitish slough along with the blisters and ulcers. So that is the essential difference between the two types of burns. That is one. Then why cannot use what we were discussing? So I don't think there was anything else which up to these questions there was any answers left. Veena ma'am, you want to say something?
Veena ma'am. Veena ma'am.
Yes, Neela ma'am. So I think the time for both of us have already exceeded. It was 10 minutes.
No, ma'am, we have 2 minutes more. You can ask any question and just answer it, ma'am, immediately.
So one question from my side to both the teams, whoever wants to take, you can go one by one. In such a patient, when you will encounter such a patient in the ER, what are the other referral consultations you need to get done?
Ophthalmic consultation.
Team A.
We need to do
Team A, please.
Yes, ma'am.
Why ophthalmic consultation?
Ma'am, as in the third picture, we could see that there was a right eye affected for the patient. So I would like to take an ophthalmic consultation also regarding the vision of the patient and scleral injury, ma'am.
So even if there is no problem in the vision or scleral injury, will you not go for an ophthalmic consultation? Like any periocular burns, do you
Yes, ma'am.
routinely go for it or not?
Yes, ma'am. Because there are chances that ectropion might develop at a later date, ma'am.
Tropion doesn't require an ophthalmic consultation.
Yes, ma'am. Ma'am, scleral exposure will lead to exposure keratitis, ma'am.
That will be done later. I'm asking in the emergency only.
Yes,
Even
ma'am.
if you have done the preliminary checkup, that patient is not having any vision problem, then also periocular burns need to get the ophthalmic consultation just for documentation also. Okay.
Yes, ma'am.
Because you might not be the right person to understand whether the vision is all right or not in the first go. So always take ophthalmic consultation.
Yes,
Second one,
ENT,
any
ma'am.
other department?
ENT consultation for the airway burns.
For what?
Airway burns, ma'am. ENT consultation.
Airway burns.
ENT consultation to look for any airway burns.
No, but this is a chemical burn patient. No?
Yeah, you can have, but I don't know whether you need an ENT consult for managing airway burns. So what are the other more important people that you need to be in your team?
Ma'am, since it is a case of vitriol, the medical legal team, forensic team must be informed.
Medical legal team means be specific. You will be attending.
Forensic medicine and toxicology should be informed for this. Not for managing, but for the cases of
FMY only when a patient. You said toxicology, fair enough. Then
Team B, we can pass the question to Team B, ma'am.
For the
you can take up this question.
for the management of pain, we have to refer to the anesthesia and pain medicine, pain management, and also for the airway and ABG analysis.
So who will make the prepare the injury report for this patient?
Ma'am, if they are not answering you.
Someone has to be presented while you are writing the injury report, because this is a medical legal case. Whom should be present when you are preparing this injury report?
Time for answering. An answer.
Medical officer, CMO of the ER, ma'am.
Anything else? You have it in your emergency, in the trauma also, in your emergency also, for all these medical legal cases?
The trauma surgery team, ma'am, prepares the PIC. Plus,
But do you require a police person? Do you have a police picket or a police station?
Yes, ma'am.
Police information.
Police
report, ma'am.
information.
Okay, ma'am.
PI report is sent, ma'am.
Yes.
Okay, ma'am. Can I move to?
One second, Rohit. It is hinted to Dr. Neela, madam. The second team told deep superficial third degree burn. Sorry, my voice gone. Superficial third degree burn. Is the term acceptable? Team 2 told.
no, I don't think they said superficial third. They said superficial second degree. The term itself is not acceptable in chemical burn. You really cannot assess a thickness in any chemical burn at all in the acute setting. Yeah, you cannot accept. You cannot assess. You will have to wait until it heals to find out really what happens. What is the degree of what is the depth of the burn, and then only we can assess. So that is something which they are not in any chemical burn. They are not supposed to say superficial or deep.
Superficial third degree, they said. That's wrong.
Thank you, sir. Any comments from Panse, sir?
So I have
Any
a question to team A, if I am supposed to ask.
Yes.
Suppose there is a patient with stab injury, which is also a medical legal case, and then there is a case of vitriolage, which is also a medical legal case. What is the difference between these two cases? What is more important that we do in case of vitriolage? Team B. So essentially, vitriolage is a notifiable disease. As per the current regulations, we need to notify it to the government. Neither homicidal burns nor assaults they are not notifiable. Vitriolage is notifiable. Now, one second quick question. how will you prevent hypertrophy in these burns? Team A, how will you prevent hypertrophy? These are burns. These are likely to go into hypertrophy, right?
Sir, we need to ensure that the healing of the burn is as soon as possible. So initial, a good removal of the eschar and a good dressing will ensure that the burn heals within 3 weeks in order to prevent scarring.
Sir, especially in cases of a periorbital one, we need for an early grafting to prevent atrophy on an hypertrophic. If we will follow early debridement and grafting, followed by which once healing has started, we will follow other general principles to prevent hypertrophic scar, like massaging and UV protection and pressure therapy massage and
Right. So, quick question for Team B. Anything you would like to do to prevent implications of the eye, the burns involving the eye?
Yes, sir. I would like to initially I would like to irrigate the eye with the saline and thorough wash. Followed by I would like to add cycloplegic, anesthetic drops like prilocaine, and after that I would like to add cycloplegic drops, and along with for the prop and also atropine drops. And after that, I would like to add this one steroid drops for the after rehabilitation occurs, and for further protection, if it is required, then I will go for torsorrhaphy.
Which torsorrhaphy?
Sir, there are two types of torsorrhaphy: approximation and tongue or torsor.
Central, lateral, permanent, temporary.
Sir, temporary torsorrhaphy, sir. Central temporary.
Okay. I'm done.
Okay, in chemical burn, you have to go for a torsorrhaphy only if you're sure that there is no trace of the chemical in the eye. So that you will have to be very, very careful. When you have irrigated enough, you have the wound, that it is stable, it is not progressive. All those things have been to be assessed before you can plan a torsorrhaphy. Because after you plan a torsorrhaphy, you really cannot see the eye and examine what is happening to it. So you'll have to be very careful in that. It's not like the other burns of the face where you can do a torsorrhaphy preemptively.
Yes.
Yeah, Rohit, please put on the second one.
Yes, sir, sure, sir. Second spotter, I would like to request Bhattacharya sir and Rajmanas sir to lead the questions.
Bhattacharya sir. Okay,
Dr.
Team
Rajiv
A.
asked-
Yeah, Team A, can you describe both the photographs? What kind of, what is the depth and extent of the burn? These two.
Sir, in this, we can see that there is second degree superficial and deep burn present over the dorsum of right hand. There are two red erythematous area and whiter area. Whiter areas are the deeper areas. This is after debridement of superficial epidermal peeling has been debrided. While in second image, we can see it is a deeper burn, sir. There is white areas of patches, and probably there can be component of compartment syndrome. Dorsum of hand, there is edema in dorsum of hand in both pictures. It appears to be a circumferential burn.
So Team B, as he told, that is a deeper burn. How much deep it is? The second photographs, can you tell? Seeing the color and appearance.
So based on the color and appearance, it looks like a full thickness, the 3rd-degree full thickness burns, and
How much the extent of the burn in both the photographs?
sir, in the second photograph, which is on the right side, the extent of the burn is from the 2 centimeters above the elbow till the dorsum of the fingers, till the above the MCP joints of the fingers and the base.
Yeah, extent we calculate in the term of percentage actually. So how much percentage it will be?
Sir,
Basically 4%
Both.
it is approximately
both
Team
answers 9% for both.
9%, sir.
Okay, let us take it 9 or 8 to 9%, right?
Yes, sir.
What do you think is the mode of injury?
Mode of injury, right?
Sir, for the first picture, it appears to be
First means
scalp.
right or left?
Sir,
First,
the right, sir, the right arm which is being shown, it appears to be a scalp burn, sir. In the left side of the picture, sir, it appears to be an electrical burn. It appears to be a 3rd-degree deep, sir.
30-degree deep can happen both in thermal as well as
Yes, sir.
electrical. What
But
makes you
because
feel
it
that
is
it
a
is electrical?
sir, circumferential burns with, it looks like a circumferential burns with impending compartment syndrome, sir. I would like to go with the diagnosis of electrical burn, sir.
plus,
But these things can happen in both electrical as well as thermal.
so there is more injury at the flexor crease in left hand. We can see that at wrist and elbow joint, which can be happen in electrical burn.
But is there any sign of charring or necrotic areas as it more happens with electrical burn?
In the proximal part, there is a translucent area with blackish discoloration, sir, as well as on the dorsum at the near the knuckles. Sir,
But
it
on the
appears to be-
left it is not there.
Sir,
Left
sorry,
picture.
sir, talking regarding the left picture, sir.
Yes. So this pinkish area in the
Yes, sir.
arm, how does it occur in your mind? What it could be? Electrical or thermal?
So more of thermal burn.
More towards thermal burn, sir.
Because electrical is usually a progressive burn.
Yes, sir.
Why it is progressive?
So because damage appears from deeper structure, basically two structures, skin and bone, are having most resistance and suffer maximum thermal injury. Muscles breakdown happen, bone injury, the maximum heat is dissipated near the bone. So
the question is straightforward.
Yes, sir.
Why in electrical burn the tissue damage is progressive?
Sir, in electrical burn, sir, as the conduction medium is the nerves as well as the blood vessels, sir. So the blood vessels, sir, microthrombi start occurring, and that gradually progresses over the next 2 to 3 days, causing ischemia and further necrosis. Sir, it burns from the electrical burn is from inside out, sir, because bone is the most resistant structure, and it heats from the inside. So muscle necrosis is because of that, as well as the blockage of the vessels, sir, because microthrombi start
So
occurring.
in the left picture, there is already a sort of demarcation between normal and this pink area, the wound. Do you still think that it is electrical burn, as you diagnosed earlier? In B?
Sir, if it would have been electrical burn, there would have become arcing phenomenon will be there at the wrist joint and the elbow joint. So I would like to go towards the thermal burn, sir. The first picture, the pinkish area, the
So
left.
team A, what will you ask the attendant of the patient documentation?
Beg your
That
pardon.
will give you the answer.
how this injury happened, sir? We'll ask about the history of burn. How did he suffer the burn?
Dr. Manas.
Yes. So both the pictures belong to the thermal burn only. Okay, you talk about the compartment syndrome. How do you diagnose compartment syndrome?
So diagnosis
By
for
seeing the
compartment.
picture only, you can't say that this is a compartment syndrome.
Yes, sir.
Yes,
So diagnosis will be primarily clinical, sir. We will be having a circumferential burn. We'll have firm outer skin, and it will be tensed. There will be difficulty in passive and active movement of the fingers, while other features like numbness and pulselessness is a late feature, sir. So
Sir, passive stretching to pain is one of the most cardinal clinical examination which gives away the compartment syndrome, sir.
Okay, the 5 P's are there. So paresthesia, pulselessness,
pulselessness,
chronic heart,
pain,
pallor.
pale.
So can you just, team B, can you just enumerate the clinical appearance of both these pictures? Why it is 2nd degree superficial and why it is deep?
Yes, sir.
No, I think all the questions have to be to team 1 first.
Okay,
and then
team
to
1.
team B.
Yeah. Just enumerate the.
If they don't answer, then team B.
Sir, second degree superficial will be having superficial blisters. It will be erythematous red, will blanch on a compression. Second degree deep will be having thicker blisters, or the blisters will be retained. It will not be easily bursted. It will be relatively white, and it will be insensate to pinprick. While third degree deep will be white in color, and full thickness burn will be charred, sir.
Okay, so team B, anything you want to add into it? Blisters, color, blanch on pressure, capillary refill, pain,
Superficial.
everything is done.
Sir,
How much? How much?
Blister formation.
blister
Yeah,
formation will be there, and
in both.
The
Yeah.
second degree superficial burns, a blister formation will be there, and so there'll be pinprick
imprint.
bleeding signs, and so in second
Pain will be there.
Yeah,
in the second degree
you are not
superficial.
going to pinprick the burn area. Do you do that?
Nice, sir.
Yeah,
And pain will be there in the second degree superficial,
more than
and more than the and there will not be any pain in the full thickness burn, sir.
Okay, so how much time they are going to take for healing? The first and second picture. Team A.
The second.
So second degree superficial burns usually heal by 3 weeks, sir. Second degree deep to third degree deep, they will take more time, sir. So that is why we.
How much more time?
Sir, second degree deep and third degree deep, they heal by wound contraction, sir. The contracture, that is why the contracture occurs in these cases, sir. So that is why we go in for early excision and grafting in order to prevent the complications, sir.
So 2 weeks for second degree superficial. For second degree deep, it will be 3 to 4 weeks, while third degree will take more time, around 3 months.
So that will not heal on
biceps.
spontaneously, sir.
Yes.
We need to go in for excision and
That will heal with the hypertrophic
yes, sir.
scarring.
Otherwise, it will result in contracture, sir. Yes.
So
what will be your mode? What will be your mode of management?
Sorry to interrupt. Given 10 minutes is over.
Okay.
Just management part, maybe they can answer.
Yes, I mean, it will be like much.
Sir, you may please answer the unanswered questions, sir. Dr. Rajmanas, if there are any unanswered questions, probably you can.
Yeah, I think I already discussed about the compartment syndrome. So you need to diagnose it clinically. The first sign will whether you will get it the paresthesia. Understood. Now the nerve fiber which is first to get involved, first to get compressed. The pulse things that comes in the last, right? So pilar paresthesia, pain on passive stretching, then a stony heart on palpation, then the loss of function will be there, right? So those things you have to, that is the clinical diagnosis. By seeing the photographs, you cannot say just it's a compartment syndrome. And both the pictures belong to the same patient, not electric burn or scald burn, both the thermal burn only. Electric burn will have a different features like Dr. Bhattacharya has told, right?
So since there is more time, so can you tell me your mode of management?
Yes, management part.
So we will go for an early, after clinical diagnosis of compartment syndrome, we will go for an early decompressive surgery, which is fasciotomy for.
By looking at this picture, do you think the patient requires a decompression?
Clinically examined.
So we need to
Forget about the compartment syndrome. There is no
left hand.
compartment syndrome.
We are. It appears to be requirement is there because it is third degree burn. Plus there is edema of over dorsum, which appears to be tense, sir. So it needs early decompressive surgery. We'll make fasciotomy incision. We'll explain the patient. We'll also look for any signs of rhabdomyolysis.
Why do you say fasciotomy? Decompression is same as fasciotomy?
Sir, depending on eschar versus if it is being relieved on escharotomy only, then we'll call it as escharotomy. But if we require the opening of fascia so that muscles bulge out, then it will be called as fasciotomy, sir. In upper
So suppose you don't incise fascia, what happens? Do you get the benefit of decompression?
No, sir. It will again land up into the sequelae of ischemic contracture. Basically, the blood vessels will be still in.
How will you decide the adequacy of your decompression?
The muscles must appear bulging out, sir. After giving incision on fascia, the muscles usually bulge out from the
So,
right body.
so an wound which requires fasciotomy, and the fasciotomy was delayed. And after the muscle herniates, what will be the color of the muscle, and how do you decide that these muscles are okay?
Sir, on appearance, if the muscle
I'm
is
asking early decompression versus delayed decompression.
sir, on early
Particularly muscle.
decompression, the
Yeah.
muscle will be red, normal appearing, while in late decompression, it will be dusky in color, and uh, it will be dusky, sir, and it might also not react to the electrocautery. We can see the viability of muscles
So the
on.
bleeding in the late cases, sir, bleeding might not be there and contractility will be gone if they are dead necrotic muscles, sir.
So what will be the implication in the final outcome?
Sir, there will be more chances of reperfusion injury and acute tubular kidney damage in cases of late decompression.
I think we can go to the third spotter.
Sir, moderator question.
Moderators.
Nikhil,
Yes,
can
please.
you can
Sorry.
Yeah.
Sorry, Nikhil.
Yeah, you can ask questions and comments also. You have 5 minutes to
Sir,
go.
I have one question each for team A and B. So in this, we saw the clinical picture of this patient. So post-op, or you will be immobilizing the patient in this position, MP joints in flexion and IP joints in extension. So for team A, why would you like to immobilize IP joints in extension?
Sir, so that the dorsal extensor apparatus and the collateral ligaments are maximally stretched and they do not land up in contracture, sir. Otherwise, the patient might
That is the second important reason. For IP extension, what is the first most important thing?
Sir, this is the functional position or the glass holding position.
We are talking about physiology.
Yes. Sir, because when there is development of burn edema, their joints are MCP joints try to attain at extension.
IP joints.
IP.
See, IP joints, it is more about volar plate contractures. Question for team B, why do you want to immobilize MP joints at 90 degrees?
This will also go to team A.
Yes.
If they don't answer, then team B.
Okay, team A.
Sir, because when there is a edema, MCP joints try to be at a maximum joint space, which is in extension position. And since dorsal skin is much thinner, it contracts more. There is a MCP.
More reasons.
Sir, another reason will be the same that since a functional hand is a glass holding hand.
More reasons.
We can pass it to team B, sir.
Team B.
Yeah, team B.
Sir, we'll do the extent flexion of the MCP joint as a to prevent the contracture of the collateral ligaments and also as a tenodesis effect, and to prevent the volar plate contracture for the IP joint extension we will do, sir. And also there
Does
will
it have
be
anything to do with the shape of the metacarpal head?
yes, sir. The metacarpal head is round shaped and because of the round shape, the phalanges the phalanges will be
so you have been answering it in a bit haphazard manner. So this is one of the most important things. Both the teams read it in depth, in detail. There are almost 4 to 5 reasons for that: MP joint flexion and IP joint extension.
Fulcrum.
Yeah.
You may mention it.
So for MP joint, it is mainly related to the collateral ligaments, the head of the metacarpal. For IP joints, it is about the volar plate contracture. And most importantly, for both these things, rehabilitation is much easier. It is much pain-free. From this position, it is very difficult to immobilize. It is very painful for the patient. From this position, it is very easy to rehabilitate the patient. It is very pain-free. And obviously, edema, lymph fluid, easy mobilization, these are the factors which facilitate easier improvement in the outcome.
Okay, sir. Judges, Sudhakar sir, do you have any comments?
No more comments. Rohit, you can go for the next case.
Okay, third spotter.
Third spotter.
1 second.
Sir, okay.
Regarding the blisters, the question is anybody can answer, or team 1 or team 2. Regarding the blisters, on the presentation, there are no blisters, the only red color is there, or a few blisters are there, but most of it is red color. Which one you will declare to the patient? Which degree? It is superficial or so deep or second degree or first degree, and why?
Sir, if the blisters are there and which are not easily being ruptured and it is maintaining its
Rupturing, no,
shape, then it is
appearance. I'm
likely
asking about the appearance, time of appearance. Okay, I'll answer to save time. The appearance is the immediately what blisters are appearing, they are definitely deeper than first degree. But the point is, second degree burns, superficial, rather, so relatively superficial degree, second degree burns, blisters will not appear on the same day. They can appear the next day also. So the absence of blisters with a reddish color cannot make you declare to the patient that it is first degree, and it will go in a few days' time. So be careful about the timing of blister. Be cautious while committing to the patient. That's all. Over.
So thank you, sir. Now moving to the third spotter, sir. I would like to request Veena ma'am and Rajmanas, sir.
So team A, can you identify the instruments?
Yes, sir. It's VersaJet, sir.
So why it is used, where it is used?
Sir, it is used for debridement with a sir. In the curve of the instrument, sir, there are fine holes through which saline comes out at a pressure, which helps with the debridement of slurp, sir.
So team B, I can't see them.
Sir, it works with the principle of Venturi effect that uses the high pressure jet of a fluid to cut and remove the dead ablated tissues. And it's basically hydrodissection and also to remove the foreign matter. And also it also uses to remove the foreign bodies which is present in the hand in the blast exposures, all those things.
Team A, what are the advantage of VersaJet or this hydrodissection or what the conventional debridement, what we do?
Sir, it is less painful. It debrides superficially. The slurp is being debrided. There is a minimal blood loss as compared to conventional surgical debridement.
Team B, anything you want to add?
Sir, it helps in dermal preservation. Mainly it helps in dermal preservations.
Is it dermal?
Sorry, sir.
Is it dermal only?
Dermal
Epidermal also.
Epidermal also.
So team A, what are the disadvantage of using this thing? Or limitations or disadvantage or?
Sir, the deeper debridements cannot be done using this device, sir. And after 30 minutes, sir, the rotator head also, sir, for one session, it lasts for 30 minutes. So for a very large area, it is not useful, sir. Plus,
Sir,
it is very not affordable for the patient usually, sir.
Other disadvantages are that it cannot be used in extensive burns and larger burns where we will ultimately have to require some surgical debridement. And cost of VersaJet is high, which only few limited centers are affording at present, sir. So if we are anyways planning for a surgical debridement in a larger wounds, then a surgical debridement will be better than utilizing both the methods simultaneously.
Team B, as team A told that the deeper area cannot be debrided through it. So can you tell me that how much deep it cuts? And how much deep you cut from the conventional debridement using a skin graft handle?
At what level they ask basically?
Sir, till the subcutaneous tissues we can go, sir, not below that.
We are not using, why you want to go till subcutaneous tissue?
Epidermal, basically, epidermal.
If
you have to preserve the dermosness.
You're mainly using it for the second degree deep burn or the full thickness burn, right?
Yes, sir. Yes, sir.
So how much deep it cuts? VersaJet.
Layer by layer.
Thicker, maybe thicker thickness you can tell. Like we measure the thickness in terms of millimeter or?
So we cannot remove eschers using Versajet, but so we can go layer by layer for second degree deep burns and third degree burns, sir. But we cannot remove eschar using Versajet, sir.
Okay, Dr. Bina, anything you want to ask or add?
So my question would be, what are the types of debridement for burn wounds?
Ma'am, there can
different
be a
methods.
surgical debridement. There can be enzymatic debridement. There is a there's a hydro debridement using Versajet.
So what are the surgical debridement
Ma'am,
methods?
surgically we can do tangential excision. We can do serial excision, and while
What is tangential and what is serial excisions? Are they same or different?
ma'am, tangential
Different,
excision
both are
is
different.
usually done using a Humvee knife and a grafting blade, where
And serial excision is done?
Ma'am, there's tangential excision and then ma'am facial excision for deeper burns. For
Yes,
tangential.
yes. Otherwise, tangential and serial are both
Yes, ma'am.
same. Okay.
Yes, ma'am.
You have tangential, you have facial. Which one is better?
Ma'am, it will depend on the burns, ma'am. But ma'am, we would prefer to go with the tangential excisions because if we remove the dead necrotic tissue layer by layer till we see fresh punctate bleeding, so we can stop on that layer, do the hemostasis, and then cover it with the graft, ma'am.
Is there any disadvantage of tangential excision?
more blood loss, ma'am.
More blood loss. So why would you prefer that over the facial excision? What is the disadvantage of facial excision then?
Ma'am, it will require other definitive methods for reconstruction, since direct grafting will give a poorer contour defect and a scar. While in tangential excision, we can preserve dermal components depending on the depth of burn. So a better scar and faster healing can be expected in cases of tangential excision.
Complex, I mean the reconstruction part in facial excision, it will require either a full
Flap
thickness
coverage.
graft or FSG would not provide that much good appearance as compared to
Yes, ma'am.
tangential excision. But then you have to take care of the blood loss in the tangential. Okay. What are the methods of enzymatic debridement?
Ma'am, we are using bromelain currently is the standard for enzymatic debridement. Previously, we were also having studies regarding papaverine and papain and regarding papain, sir, substance extract from a papaya, while bromelain is from pineapples, ma'am.
So are you aware of some commercial ointments or creams or
Devi Days is one which is available in India, while bromelain ointment are not currently available in India.
But these are not commonly used for the burn wound. Okay. Neela ma'am, you want to ask something? Neela ma'am is not there.
I think
No, I am
we are
there,
done.
but then
Yeah, I think
it
only
was
I and Dr.
covered
Bina is covered.
comprehensively.
Yeah.
Okay.
Are there any clarifications which they haven't answered properly, or you want to tell it in
Yeah, I think they answered well. So only disadvantage of using Versajet is that, of course, the cost is very high. Not everyone can afford it. Not every institution have. Second thing, it releases kind of aerosols that may pollute the environment. So that you need to take care of, right? And of course, it has advantage over the conventional debridement what we do.
So thank you. So I would like to ask Nikhil Panse, sir, do you have any questions or remarks for the students?
So the team A talked about the Venturi effect. So what is the Venturi effect?
So Venturi effect explains that if there is a narrow lumen, then velocity is increased. Sir, the flow remains constant, and then kinetic energy and potential energy depends on the vessel diameter. Since it will be forced to a narrow opening, then the velocity will be increased, which will lead to increase in kinetic energy of the air of the saline stream, which will be coming out. This kinetic energy will be helpful in debriding the slough.
Is it? I am not sure. I think basically it has got something to do with the
Reduction in fluid pressure.
Suction. Venturi means it's a
suction.
suction device.
It creates a vacuum and a suction. So that is making
Yes.
Vacuum and suction.
what I
Yes.
believe. Question for team B. No, again for team A. Who you talked about tangential excision. Can you tell us a bit about history of tangential excision?
Yes, sir. A Yugoslavian surgeon named Zara Janzekovic introduced it for the first time, sir.
So what was her groundbreaking thing which she proposed, and what was different from that point of time?
She was the first one who introduced that we can go layer by layer for the debridement rather than going for the deeper excision at the same time. So that till the time punctate bleeding is visible, that is the healthy area. So sir, this was the first time when somebody did it.
And how much area should be tangentially excised at one point of go?
Sir, initially 15 to 20% was done at one go, sir, but now in centers where facilities are available and blood and blood products are available, up to 40% in one setting can be done, sir.
Right. Okay. That's all from my end.
Any questions from judges or any other senior faculty?
Yes. Question for team 1. How long you can use Versajet? 1 day, 2 days, 3 days, 4 days, 1 hour, 2 hours?
Sir, for the one rotator head lasts for 30 minutes, sir.
I'm not asking that.
Yes.
Whenever you are using it,
Yes,
how
sir.
many days? 1 day, 2 days, 3 days? How many days you can use it? Each time it is 30 minutes, agreed. But how
Yes.
many days you can use it?
So,
Up to how many days you can use it? Team 2?
sir, it's one time use works.
Okay. Next question is to team 1. What is the ideal wound for the Versajet use? So these are interrelated questions. I will answer if you both cannot answer. Team 1.
What is ideal?
Ideal wound for Versajet.
Sir, it should be a superficial wound with loosely adherent slough, and there should be no scars, sir, for Versajet.
Partly correct. Team 2.
Sir, if there is any chronic non-healing wound with granulation with fibrosed wound, then Versajet would be a good option and also with the biofilm.
Yeah, both are correct. The right answer is you can use to any number of days. It is not restricted. The ideal wound is the healing wound with patchy islands of non-healing areas, rather thick areas. So those things you can nicely remove without much disturbance to the healing wound from the deeper dermal elements. The epidermis spreads without disturbing much to them, and without maximal bleeding. You can remove those eschar areas, islands of eschar areas. So there is no time limit. As long as they are there, you can keep on using. Of course, each time it will be half an hour. Over.
Sudhakar sir, any comments or shall I move to the team 2, sir? Team 2 session.
Go ahead with the second team now.
Okay, sir. Thank you. Now I'd like to request Megha and Sadish. So if your first spotter is, yes, I would like to request Veena ma'am and Raj Manas sir to lead the question.
Stop telling everything.
Team B, right?
Yes, sir. Team B, sir.
So team B, can you make the diagnosis? What will be the etiology of this burn? And
Yes, sir. This it looks like the inhalational burn along with inhalation thermal burn. In this patient, there is a presence of edema of the face, and there is a thermal burn over the forehead and face, nose, and also periorbital swelling with the lip swelling. And there is
Extended to the upper part of the chest.
and it is extended to the upper part of the chest. It looks like 30-degree burns, and also the face looks like mixed burns. And there is also I'd like to check for the, and there is singeing of the eyebrows, and also singeing of the eyelashes, and the nasal hairs singeing is there, and periorbital swelling is present.
What else you will ask in the history that will diagnose that is the inhalational component?
Sir, I would like to ask whether the
Burn was there in a closed room or not, sir?
closed room or not.
What else? Team B,
And also
Team A, anything you want to add?
Sir, and also there is the time, the extent of injury, that how much extent of exposure, duration of exposure. Duration of exposure is important, and also the cause of the exposure, and what are the irritant gases were present, combustion gases were present during the time of injury.
Team B, Team A, you want to add anything into it?
The clothes the patient was wearing, whether it was removed immediately or not, patient was taken out from that area of accident immediately or not.
Okay.
Then we'll ask about any respiratory discomfort, any
discomfort.
Sir, I would also like to know if he was taken initially to any other center, and if any form of resuscitation has been given to the patient prior.
Okay. Okay. What else? Anything left?
So whether water was poured on the wound immediately after the
That is
accident
all
happened.
right. Regarding inhalational component.
Sir, is there any hoarseness of voice is present or not? That I would like to
That
say,
is
sir.
one. What else?
Cider
And
history of unconsciousness.
Unconsciousness is
Yeah, that you need to ask. So team B again, when the patient comes to emergency, so how you are going to proceed?
Sir, we would like to divide into teams. For the first team, one team will be taking the history, and another team will be with the patient with intravenous access will be given, and also the hydrotherapy will be given, and also the airway assessment will be done, and the cervical spine stabilization along with the airway assessment given, and
How
breathing.
will you assess the airway?
Sir, airway assessment will be done with the help of a laryngoscope, and we'll see is there any presence of edema in the vocal cords, and if there is any progressive edema is present, then I would like to take anesthesia department help, and we'll go for intubation.
Okay, team A, would you like to add anything into it? Apart from laryngoscope, can you do anything else?
Basically, we'll ask the patient about his name and what happened. If he's able to speak well and there is no hoarseness, we can consider that there is no inhalational burn or edema currently. Although if there are other stigmas of airway burn, like we can see edema is over there, and carbon particles and singeing of nasal hairs are there, we can suspect that there can be edema later on. We will have to monitor saturation on a regular basis. If there is a drop in saturation or there is a subjective dyspnea, we can go for an early intubation in cases of airway burn, sir.
So which is more diagnostic, laryngoscope or anything else?
The clinical assessment first. So
how
the
will you assess there is a
assessment.
severity of airway?
Clinical assessment with hoarseness, stridor and hoarseness, sir.
Singeing of nasal hairs.
And also soot particles present in the oral cavity.
Then bronchoscopy is more diagnostic, right? What other investigation you will do apart from bronchoscopy?
So I would like to go for arterial blood gas analysis to check for any carboxy hemoglobin levels. And
any carboxyhemoglobin?
To check for the this one arterial blood gas analysis to check for the COHB, sir, carboxyhemoglobin levels.
How much it should be?
Sir, it should be less than 10%. It should be less than 10%.
Team A. What is the normal carboxyhemoglobin level?
Sir, carboxyhemoglobin should be less than 15%. More than 15% can be due to CO poisoning, symptomatic CO
We're not
poisoning.
talking about CO poisoning. Normal level, normal adult.
It's like 1%, I think. 1%. 1 to 5%.
He
Should be less.
told us that it will go till the 10% or
In
maybe
smokers, it is till 10%, sir. Otherwise, it is less than 5%.
Less than 1%.
Yeah.
In smokers, if there is history of smoking,
So it should be 1 to 5%.
1.5%.
1.
Right. What else what investigation you will do apart from that team B, ABG and bronchoscopy?
Sir, I would like to send all the baseline investigations, here, CBC and RFT, LFT, and
Hematocrit.
hematocrit. And also I would like to send for procalcitonin and CRP. And
how will you assess the damage of lung parenchyma?
Damage of lung parenchyma.
Yes.
sir, with the help of chest X-ray,
Can you? Team A.
Whitewash lung.
Sir, HRCT is required for
HRCT
lung
will be more
parenchyma
required.
assessment.
Yes, yes.
HRCT is required.
So team B again, how you are going to manage?
Inhalation.
Yes.
Sir, I would like to manage with the, after intubation. I would like to manage with the airway, then blood circulation, and fluid resuscitation will be managed from the time of injury. We'll start the.
How much fluid you should give in a saline burn?
Sir, according to Parkland's formula, we'll measure the percentage of burn multiplied by 2 ml and multiplied 4 ml and with the body weight.
Again, if you give more fluid, then there will be a pulmonary edema. This is already in respiratory distress. Team A, how much fluid you should give?
Sir, initially we would start with the Parkland formula, sir, but we will keep monitoring the urine output as well as the IVC diameter in the facilities.
How much urine output should be
Sir, 1
titrated?
ml per kg per hour would be the
It's a
0.5
1 to 2.
1
In
ml per
national
kg.
burn also like electric burn now, we should keep it at more higher level, right? Dr. Beena, anything you want to ask? Sorry.
Actually, Veena ma'am is not there, sir. Bhattacharya sir will take over, sir.
Okay.
Bhattacharya, sir.
Bhattacharya, sir.
Veena ma'am, she has some work, sir, so she left.
Okay. So you intubated the patient. Anything more you want to do? Any nebulizer,
Yes, sir.
bronchodilator?
Would like to give bronchodilation and nebulization, and also hep saline nebulization will be given. And also I'd like to give steroid nebulization also, like Budicort and bronchodilator like Duolin.
Team A.
Sir, apart from that, heparin and acetylcysteine nebulization can also be done.
Already covered.
What is the dose of heparin and acetyl?
Sir, 10,000 units of heparin will be diluted in 10 ml of saline.
3 ml.
3 ml of saline, sorry, sir. 3 ml of saline.
So in such facial burn, what important history will you inquire about?
So many a times, sir, these facial burns can happen while cooking, sir. They are more commonly seen in female patients, sir. Mostly when
That's
they
okay. That's okay. Any other specific history?
So opening of a pressure cooker while cooking and getting the flames.
Those are mode of injuries. I'm asking of anything special.
Sir, is there any
about the patient, about the mode of injury or the patient itself?
Any
Team A?
Sir, history of any seizure disorder in the patient?
Exactly. Yes. History of epilepsy and the mode of injury.
Loss of consciousness.
And team B, suppose this patient has come and almost having difficulty in breathing, and the anesthetist is not able to intubate. What are the options for you?
Sir, a tracheostomy.
See, the area is very edematous. By the time you are preparing for tracheostomy, anything else the anesthetist can try, which is maybe most of the time very useful.
Picothyroidotomy or a mouth. Airway.
Anything else between fiber optic or intubation? Anything else more simpler?
A cricothyroidotomy, sir.
Cricothyroidotomy.
No, non-invasive.
HFM.
Team A?
Hypronasal oxygen.
Laryngeal mask airway.
Yes, yes.
At the end,
Laryngeal is very useful because no, it immediately sits over the larynx and they can save much important time.
yes.
Okay.
They answered well. Anything?
Okay, sir. If they haven't answered any questions or with more clarity, if you want to tell, you can tell in this 5
I
minutes.
think they answered well.
Okay, sir.
So maybe
Can we move to the moderator?
moderator's remark.
You talked about biomarkers. You talked about carboxyhemoglobin levels you would like to get done. Any other biomarker you would like to look into, considering the history in a closed environment and you diagnosed it to be a case of inhalational burns? Apart from carboxyhemoglobin, which is for carbon monoxide.
Yes, sir. Methemoglobin levels.
Yes.
Methemoglobin levels.
Yes.
And
What is that for?
sorry, sir.
What is that for? What do you want to look for?
For cyanide poisonings.
Right. For cyanide poisoning. Right. So another thing is, now that you have diagnosed it as a inhalational burns in a closed environment, what is the first thing you would like to do for this patient?
First thing.
So we'll have to take the patient out of that
Exposure.
room, sir, and take the patient to fresh air, remove all the clothing that are there on the patient, and put the patient
Then
under
oxygenation.
water.
Oxygenation to be given. First of all, you should start with 100% oxygen, sir.
So why is that? Why is that the first modality which you should implement?
Sir, to push out to give 100% oxygen, because the
Carbon dioxide retention.
yeah.
To reduce the carbon dioxide retention in the patient, sir.
So carbon monoxide has got more affinity towards
the hemoglobin, sir.
Yeah. So when you give oxygen, the binding reduces, and thereby carboxyhemoglobin levels go down, and the patient improves rapidly.
Yes, sir.
So that's all from my end.
Any questions from senior faculty or judges? If there are no questions, Sudhakar sir, can I move to the second spot?
Yeah, go to the second spot.
Yes, sure. I would like to request Neelam Bhattacharya ma'am and Bhattacharya sir to lead the questions.
Dr. Neela, please carry on.
Yeah, team B, I think.
Yes,
Team B, can you just again let us know what do you think?
Yes, ma'am. Ma'am, this is looks like a post the ectropine of the right upper lid and lower lid, and along with the exposure keratitis of the cornea, and also there is a epicanthal fold on the medial side with the and there is hyperpigmented patches in the over the cheek, and hypertrophic scar of the right side of the angle of mouth, probably due to post-burn contracture of the chemical imbalance injuries. Post-burn sequelae.
Okay. Again, what could the possible etiology be here?
Possibly etiology is
maybe we are only guessing, but then when you
chemical
see
burn.
Yeah, maybe again a chemical burn.
Yes,
again a vitriolage, which usually affects the face. Okay.
Yes,
What
commented on
what are you going to do?
Ma'am, first I would like to go for the eyelid correction, ma'am.
For that, just tell me what are the requirements of this patient?
Sir, requirements is we have to prevent the complication of the corneal ulcer, sir. This corneal
Everything,
ulcer,
whatever has happened has happened. Now
Yes,
you
sir.
tell me what are the requirements.
So requirement to prevent complication towards the cornea, that is corneal perforation of phthisis bulbi. For that, I would like to go for eyelid correction, sir. Eyelid surgery correction. For that, I would like to release the upper eyelid and
So
lower
one
eyelid.
is prevention of eye
Yes, sir.
to further damage.
Yes, sir.
Eyelid correction. What else?
And
Two, three.
angle.
Numerate.
And also the correction of the postburn contracture of the medial epicanthal fold for the field of vision, And also for the there's a contraction of the angle of mouth also for the microstomia.
What else?
And
Then
the hyperpigmented,
then the cosmetic
and
hyperpigmentation.
also the hyperpigmented patches for the cheek and the forehead, and also the eyebrows correction, sir, for the cosmetic appearance.
There is depigmentation also, is it?
Depigmentation, sir.
So, what will be the sequence of your treatment? How many sittings this patient is going to require?
This patient requires multiple settings, sir. One is
First sitting.
first setting.
Most important part, so what is the priority?
First setting would be the eyelid correction, sir. Corneal protection with eyelid correction.
Which eyelid?
Sir, I would like to go for upper eyelid first, followed by lower eyelid. Or
Why?
both can. Sir, upper eyelid.
Covers the upper 1/3 of the cornea.
Yeah, upper eyelid covers the most of the upper 1/3 of the cornea, sir. Exposure will be less to the cornea. Most of the cornea will be covered. Almost 3/4 of the cornea will be covered.
Okay, so first stage you are going to do upper eyelid.
Yes, sir.
Anything else? Or just eyelid? How do you decide the adequacy of your upper eyelid release or correction? When will you stop? What will you satisfy? How much do you release? How do you feel that now it is adequate?
Say whatever you mention, say whatever you know. Upper 1/3 cover when I say what?
Where will you put the incision for upper eyelid release?
Ma'am, between the eyebrow and this the eyelid margin, ma'am.
Okay, between eyebrow and eyelid margin, that area. Okay.
Yes.
That will release the upper eyelid correctly.
No, ma'am.
As sir asked, you put it at the supratarsal fold,
Yes,
and you're bringing the eyelid down. So when will you decide that you have released enough?
Yes.
That covers the at least upper 2/3 of the cornea. Upper 1/3 of the cornea.
The other team?
Yes, ma'am. Ma'am, for the upper eyelid, we always overcorrect. We would like to see till that point it touches the lower eyelid. Because the upper eyelid is the dynamic structure which covers the eye. Secondly, ma'am, I would like to examine and see where is the point of maximum contracture. On that area, I would like to place the incision and then give an overcorrection, ma'am.
Ma'am, usually the incision is given at the lid crease and it should extend little beyond the canthi for a proper release.
Upper eyelid, you cannot give it at the lid crease, because you need to bring the entire upper eyelid down, not the lid crease down, right? Because you need the entire tarsal plate, the muscles to come down. So the tarsal fold is the way. What about in the lower eyelid? But in this patient, can you do both together? The team B should take the question first, I think.
Yes, ma'am. Yes, ma'am. We could do together, ma'am. But we have to tell the patient preoperatively that one eye will be blind in the postoperatively due to the dressing.
See, you have
We are fine. So far was near.
Sir, Bhattacharya sir is not able to, the audio is not there.
That's what I'm checking, ma'am. Sir, audio has
Okay. So if you are going to do both together, then what will you do? Tell me.
You tell.
Team B.
Can you repeat the question, ma'am?
If you're going to do both the eyelids together, what is going to be your plan? From where are you going? What are you going to do?
Ma'am, the lower eyelid incision we can place at the lower eyelid crease and release, ma'am. And ma'am, the upper eyelid can be released from the medial canthi, ma'am.
Okay, then how are you going to resurface?
I'm resurface with the full thickness graft over the lower eyelid, and I would like to go for intermediate thickness graft for the upper eyelid.
Okay. Why like that? Give me reasons for your answer. You said intermittent thickness for upper eyelid and
Yes, ma'am.
a full thickness for the lower eyelid.
There
Can
is
you give me reasons? Why do you want to do that?
Ma'am, there is a high chance of secondary contracture in case of intermediate thickness or split thickness if we do for the lower eyelid, ma'am, compared to the upper eyelid.
Okay,
But
recurrence.
you said that the upper eyelid is more important than the lower eyelid.
Yes, sir.
So
But,
which will concern you more?
So
where should you put?
There will be epiphora will be there, xerosis, conjunctival xerosis will be there.
No, you said split thickness or medium thickness graft for upper eyelid and full thickness for lower eyelid.
Yes.
So how do you defend that?
Upper
On
eyelid
one
is
other
movable.
hand, you are telling that the upper eyelid is more important than the lower.
So upper eyelid is
So where
movable.
you are
That's
more
why-
concerned about?
So the upper eyelid is movable. That's why it is more important.
Mhm. So FTG will not allow it to move.
It will allow. So the thickness of the upper eyelid is lesser.
So you tell me while releasing, will you not consider this epicanthal fold?
Yes, sir.
Yes,
we
sir,
will.
we
We will consider the epicanthal fold, sir.
So you said just incision and release because this epicanthal fold has to be tackled simultaneously, isn't it?
Yes, sir.
That's the first thing.
No. So what I asked you in the beginning that what should be the sequence of your surgery, because the patient wants maximum benefit and less number of operations. So you are concentrating only on the eye or eyelids. Patient is under GA. What are the other benefits you are going to give it to her? Only eyelids?
And epicanthal fold and also the angle of the mouth. So.
Yes, why not?
Yes, sir.
There's so many aspects, the depigmented scar, the hypertrophic scar of the cheek.
Yes.
Because many a times, due to lack of massaging, etc., there may be some amount of recurrence. It's bound to happen. Patient goes back home and doesn't follow your instruction all the time.
Yes.
So you will have to have a second or third procedure. So why don't you give maximum benefit in the first go?
Yes, sir.
So what do you think about it? What are the areas which you would like to do in first go?
The first go, I would like to remove the epicanthal fold, sir, release of epicanthal fold, and also the upper lid and lower. Sir, release of the epicanthal fold along the line of the maximum tension, sir.
Any name for that?
This one. Jumping flap.
Exactly. Yes.
Jumping flaps.
Jumping man.
Jumping man flaps. Sir.
So you have to overcorrect the upper eyelid, touching the lower eyelid, as you said.
Yes.
Then how will you manage simultaneously the lower eyelid also? Would you like to do it in first stage or would you like to do it in second stage?
10 seconds.
What will you prefer?
Second stage.
Sir, after overcorrection of the upper eyelid, I would like to go for second stage to correct the lower eyelid, sir.
After how many months?
6 weeks. So after 6 to 8 weeks. Sir.
After maturation of the graft. After 3 months. After the maturation of the this one.
Definitely after 3 months.
After
There's
3
no
months.
hurry. You have to get full benefit of the
After
first
3 months.
one. Maybe after 4 months, 5 months, doesn't matter because you want to have a good relaxed upper eyelid, which you have already released and overcorrected.
Yes,
okay. So is there any role of tissue expander in this?
Tissue expander. Yes. Yes, sir. A role of tissue expander is present for the correction of the cheek deformity.
In this particular case, is there any role of tissue expansion? Suppose the right cervical area is free.
Clinical photo, please.
Picture.
Sir,
Can we get the pictures?
Can we get the pictures?
Get the picture back.
Okay.
Yeah.
Yes, sir.
Yeah, will we place the tissue expander?
If the neck area is free, we can place the tissue expander of the neck area, and we can advance the tissue over the cheek area, sir, after removal of the hypertrophic scar of the cheek.
So you said there is a contracture at the right commissure of the oral cavity. How do you
Yes.
decide the point which is correct for that correction?
Sir, I would like to go reconstruction according to the facial subunits, facial units.
And compared to the normal
So
side.
if you have to correct this right commissure, what will you do? What procedure? How will you approach this?
Sorry.
Commissure,
I think
commissure plus.
We have to do it in comparison to normal sides.
Yeah.
Does this patient require only commissuroplasty?
Sir, along
Lip also is damaged. The lip is also damaged, sir. The upper lip is
So?
also damaged, so the patient might need upper lip reconstruction as well, sir.
What about lower lip?
the whole the half of the lower lip, oral commissure, and the half of right side 1/3 of the upper lip.
So this whole thing has to be excised, isn't it?
Yes, sir.
Then how do you decide the point that this is adequate point for commissuroplasty?
Comparison to normal side.
We'll compare it with the normal side.
Normal side, sir.
Normal.
Or contralateral side.
Okay. But what do you do to the mucosa? Do you think mucosa is intact or it is damaged?
Looks intact. So
It's
the,
intact.
so the mucosa
So,
looks
in
So
photo
how
looks,
do
it
you
looks intact, sir.
maneuver mucosa? How do you maneuver mucosa for correction?
So for correction.
mucosa for correction.
How will you bring out?
Sir, hinge flap.
Okay.
A turnover flap. Turnover hinge flap. So.
Time A, team A.
Email.
If you say
Okay.
turnover flap, then you do not know what is turnover flap. So don't comment. Like
Sir,
that.
sir, viva advancement of mucosa.
Team A, anything you want to add?
Sir, for commissuroplasty, VY-plasty we can do, sir, and up to the mid-limbal region we will proceed to obtain release microstomia.
Okay.
Sir, given time, sir, allotted time is over. You can answer the
Okay.
question if you are not answered.
Yes, actually, you excise that whole scar. Can you show me the picture?
Yes, sir.
Excise that whole scar, and then mucosa is just advanced. But here, if you are seeing my cursor, if you excise the whole thing, and then you have to find out the upper border and the lower border, and first stitch of the mucosa, advanced mucosa, is to the commissure where the point should be there as compared to the normal side. And then you put few stitches from mucosa to the skin, whatever skin. Suppose you are putting a skin graft or the tissue expansion, expanded skin, then you suture the mucosa to those skin margins. Then it stays. Mucosa in such cases are usually free and normal. So at the commissure, when you are excising the hypertrophic scar, you should be very careful in preserving the normal mucosa. And then first stitch is to be at the commissure where you want it to be, and rest are to the skin margins. It's a very simple procedure, but very effective. And how will you decide that this excision will not hamper with with the opening of the mouth? Any idea? It's not, you are operating in mouth close, but just like oncosurgery, you need to do full mouth opening has to be there after your surgery. So
Yes,
how
sir.
do you decide that on the table? Team A, very simple procedure I'm asking.
Intra-procedural, we can use bite block to see if there
Bite
is
block.
no resistance while opening the mouth.
You can put bite block or you
Bite
can
block.
put Ferguson mouth opener on the normal side. Open the mouth and decide. Dr. Venkat.
Yeah. Thank you, sir, for the giving opportunity. I want to add a couple of practical points. One is the length from the midline but till this left side angle of the mouth, the length is very clear normal. So take that length and then measure it onto this side and do some sort of ink mark there, pierce it, tattoo like, do there. That stays for a long time, as long as you want the release. Second clue I want to give is, it is always better to remember the word fish tail at the angles of
Angles of
mouth or like
incision.
this. That fish tail, so incision and suturing. So that prevents reclosing, reclosure. It tends to prevent at least. So these 2 points I want to give practical points. Over. Thank you, sir.
Moderator comments, sir. Nikhil Panse, sir, you want to ask any questions?
Yeah, can you go back to the image, please? So what are, for team B, what are your goals of reconstruction of the upper lid and for the lower lid? Simple goal of reconstruction.
So goals of reconstruction is a soft, pliable, well vascularized graft over the upper eyelid for the blinking, and also for the lower eyelid, and to close the palpebral pressure completely to prevent corneal exposure, sir. And
So
also to release the epicanthal fold for the good field of vision.
So put it in a better way, it is always goal is mobility for the upper lid and stability for the lower lid.
Lower eyelid.
So how would you reconstruct the eyebrow in this case?
Sir, eyebrow, I would like to go for scalp full thickness graft, sir, for the reconstruction of the eyebrow.
You mean hair grafts?
Yes, sir. No, sir. No, sir. Full thickness graft from the scalp area, so that eyebrow will be grown. And also we could choose the posterior branch of the superficial temporal artery, islanded flap for the eyebrow.
Anything else, team A, you would like to add? Anything which would also help in your eyelid reconstruction?
Sir, we can use modified Vashio's flap for reconstruction of the eyebrow. And sir, if the bed is not very scarred, hair transplantation for eyebrow can also be done. And sir, tattooing of the pigment if other two cannot be achieved.
Can be done.
So my take on this is, see, this is a very significant contracture. It is most likely an acid burns. It is very likely to go into recontracture. So to prevent that, I would go ahead with a temporoparietal facial flap for eyebrow. Along with that, you take an extra fascia for the eyelid. So when fascia goes in, your recontracture goes down significantly. So that way you can reduce the recontracture. And one more take I would like to say, as Bhattacharya sir said, in these type of cases, you don't go for simultaneous release of the upper lid and lower lid because we need overcorrection. But also to be specific for this particular case, she has already, I believe, lost her vision. There is some infective foci in there. So eye care is also necessary. In minimal contractures, you can possibly do a tarsorrhaphy and do both upper lid and lower lid correction together. But in this particular case, that is never going to happen because we will need prolonged eye care. You will need antibiotic installation, eye drop installations. So only one eyelid at a time, and obviously upper lid is a priority. Mobility and coverage of the cornea is a priority. So upper lid only, and then at a later stage, when everything settles down, we go for a lower lid reconstruction. Thank you.
Thank you, sir. Sudhakar, sir, you want to?
Yeah. For team 2, what is the status of the eye now?
Sir, right now there is a corneal ulceration, sir.
Is it an ulcer after so many
Chronic
months?
exposure.
The scar is so
Yes, sir.
extensive. Do you call it as an ulcer now?
Opacification.
What are the different stages of ulceration of a cornea?
Ulceration.
That's taught in ophthalmology.
So the cornea is already opacified in this patient, sir.
So what is that called?
Phthisis bulbi?
No, it is called leucoma. It is white patch. It is scarred cornea. You don't have any vision in this particular eye, as you can see. So in which case, how can you protect the vision in this eye? What is your aim of performing the eyelid surgery in this particular patient?
Sir, to prevent perforation of the cornea and
Why will it perforate now?
protect the
You have to give them eyelid so that to make the patient fit for a keratoplasty later.
or to corneal transplant can be considered later.
Yeah.
That's what is called keratoplasty.
Keratoplasty, yes, sir.
Yeah, you have to make the patient fit for a keratoplasty. Whatever your reconstructive aim should be a long drawn one.
Yes.
In the long run.
Yes.
You got it? It is a leukoma which requires a keratoplasty. For that, you have to have a proper eyelids, both upper and the lower eyelid, the dynamic upper eyelid and the static or the stable lower eyelid. Okay?
Yes, sir.
That's how it should be.
Yes, sir. Thank you, sir. Can we move to the third spot, sir?
1 minute.
Yeah.
What are the methods you know of giving mobility to the upper eyelid? After release, it is almost, think that it is full thickness release.
Yes, sir.
Then there is no muscle attached to that. How will you give the mobility to that?
So we can give the gold plate.
Will gold plate give mobility? Well, gold plate is correct, but will that give mobility?
Temporalis muscle transplant. Not sure that.
Will you use a gold plate in a cicatricial ectropion? This is not the condition, no.
Yeah, not for this anyway. You're right.
Yeah.
So any technique to give mobility?
Temporofacial
Sling.
Sling, temporofacial sling can be given for the mobility.
And there are many other methods. At least one you know that. Okay, go ahead. Over.
Third spot is.
Yeah.
Like,
The third spot.
yes, sir. I have moved to the third spot, sir. I would like to request Rajmanas sir and Neela ma'am to lead the questions.
Team B, can you describe the condition?
Yes, sir. Sir, there is a ulceroproliferative growth over the right popliteal fossa, extending from the posterior part of the thigh lower about 4 centimeter from the extending above about 4 centimeter from the popliteal fossa till 4 centimeter, almost of 4 to 5 centimeter below the popliteal fossa over the posterior part of the leg. Probably a Marjolin ulcers.
With hypopigmentation
With
surrounding the
with
What
hypopigmentation
surrounding
surrounding
the
this.
ulcer.
Yeah,
and
hypopigmentation you can see.
With contracture at the tender achelis area, sir.
Okay. So what else you will ask in the history to diagnose that it's a kind of margarine ulcer?
Sir, I would like to ask the history of burn for how many years back, and also whether it was operated or not, and whether any cover was given or not, and if it was cover given, if there is any recurrence ulcerations present or not, and for that recurrence ulcer, whether patient received any treatment or not. These histories I would like to ask, sir.
duration of the
And
ulcer,
duration of the
whether it
ulcer,
is long-standing or not.
long-standing or not.
Team A, anything you want to add?
Sir, we will ask for the history of weight loss. We will ask whether there is any previous history of excision and any biopsy report which is available with the patient. We will examine for other things like lymph nodes in such case if we are most likely suspecting for a marginal ulcer in this case.
Is there any metastasis in this type a kind of ulcer?
No, sir. Metastasis is not there in Marjolin ulcer, sir.
So why you are expecting weight loss?
Still, it's a hypermetabolic state. There is a new plastic growth. There can be state of starvation and weight loss.
Team A,
yes,
how will you diagnose this condition apart from the history and the clinical examination? What else you will do?
Sir, I would like to go for a biopsy from the ulceroproliferative lesion, sir.
Wedge biopsy.
Wedge biopsy.
Which biopsy? Why
And
not
if
center biopsy? Biopsy from the central area.
So
Why from the
the
there may
central
be central necrosis in such a huge tumor, sir. So we'll prefer a wedge biopsy
Wedge
to
biopsy.
include a patch of normal tissue and a patch of the ulcer proliferative growth, sir. And so we'll have to with the wedge biopsy, sir, we'll also have to
send a normal tissue.
huh?
To send a normal tissue to see the extent of the proliferation from the areas, whether the surrounding area has been involved or not, and also the depth of invasion.
Team A, any other investigation you want to add?
Sir, I would
Apart from
like
biopsy?
to go for X-ray of the lower limb also
to see for contractures.
to see for the control.
To see the
joint space and also
depth of invasion.
And also depth of invasion, whether any bone involvement is there or not with this.
How will you see in the X-ray that how much deep it is?
CT scan we can go ahead with.
Sir, I would like to go for CT scan also could be done to see if any periosteal reaction is present or not.
Okay.
And also MRI could be done to see any soft tissue involvement is present or not with the with this growth.
Team A, anything you want to add?
Yes, sir. Sir, I would like to take a 4-quadrant biopsy and send the biopsy sample. Secondly, sir, in the imaging CECT lower limb, I would like to see because I would want to see the neurovascular invasion of the structure as well as
that is very important.
periosteum involvement.
What else? Does lymph node involve in marginal ulcer?
No,
Lymph
sir,
node
it is rare, but if it is there, then it is a sign of poor prognosis. And instead of preserving surgeries, we will have to go for an amputation.
Why in all lymph node cases do you prefer amputation? So what will be the management team be?
Sir, the management would be
yes.
Yes, sir. I would like to go for wide local excision, sir, and I will see the depth of involvement. And if there is any exposure of the vessels, neurovascular structures, then I would like to go for a flap cover.
Or the joint space.
Or the joint space is exposed, then I would like to go for a flap cover, sir.
You told wide local excision. So how much wide you are going to excise and how much deep you are going to resect?
So 2 centimeter around the skin margin, sir, peripheral, and 3D, sir, 3-dimensional. 2 centimeter.
So you go one level below, or if you go 3 centimeter below, then you will excise the popliteal vessels also, isn't
Yes,
it?
sir.
Ideally one level below.
Ideally one level below.
One level below, no?
Yes,
So that is the thing.
Yes, sir.
Yes, sir.
So team A, anything you want to add in the excision?
Also we'll have to correct the deformities.
Also, we have to correct the knee deformity, sir. If there is any deformity over the knee, then we would like to go for the external fixators.
Internal fixator?
Sorry, sir. The release of the contracture over the ankle joint, we have to go for the release of the incisional release. We have to give over the tendo achilis, or the Z plastic can be done over the tendon.
Oh, okay. You are talking about the ankle area.
Ankle area, sir.
Why this kind of ulcer develops? Why it develops over a long-standing scar?
Why this ulcer develops over a long-standing scar?
What is the etiology or etiopathology? Why this happens?
Prolonged irritation, basically repeated. Yes. So due to repeated trauma, so there's prolonged irritation of the epithelium, sir, and that leads to the ulceration, sir. Also, so there may be past history of radiation exposure, maybe.
Not radiation. Team A, anything you want to add?
Chronic hypoxia is also an etiology for
chronic hypoxia. That is one. There are a lot of theories you can, if you know, you can tell.
Chronic
immunogenic theory is there, then carcinogenic theory, then chronic irritation results in the breakdown of epithelium that causes this ulcer.
Chemical injury.
Dr. Neela ma'am, you want to ask anything? Neela ma'am is there.
Okay,
yes,
I have
I'm
3
there.
questions. Yeah. Is there anyone asking? Neela? Dr. Neela? Are you
Yes,
asking
sir.
a question? Yeah, go ahead. Go ahead.
No, sir, you can ask.
Yeah. I have 3 questions. Number 1, why is Marjolin's ulcer called an immunologically privileged tumor?
Immunologically privileged tumor. So, marginal ulcers, sir, the lymphatics are usually already damaged, sir. So, the prognosis is good, sir, and usually the depth of invasion is not very deep. So, the patient.
Good. The second question is, what is the danger of taking an edge wedge biopsy, like you said earlier, to go into the normal skin? What is the danger of it?
Sir, the skin is very thin.
So it might local dissemination.
You're opening the lymphatics.
The normal lymphatics, yes,
burned.
and it might cause local dissemination of the tumor.
Yes. The third one, who is Marjolin?
Sir, Marjolin is an actually.
Thank you.
Plastic surgeon.
Then say sorry, not a plastic.
Sir, is actually radiologist.
Not a plastic.
The other team, team 1.
The Marjolins was a French surgeon who described the development of ulcer likely to be malignant in burn cases, especially. He initially
Wait a minute. Jean-Nicolas Marjolin was a French dermatologist.
Yeah.
Okay. Right. Nikhil, are you there?
Yes, sir.
Neela ma'am wanted to ask.
Yeah. Dr. Neela?
Yeah, that is what, not a question, like just a comment. The reason why this has occurred in these patients, they were talking about causes. Now, has the burn healed like it should have healed? If it has healed properly, the chance of margin will not be there. So can you just comment on that, the teams?
Long-standing non-healing ulcer. Ma'am, usually marginal ulcer occurs in patients who have long-standing non-healing ulcers due to mostly
Why is that area a non-healing ulcer in the first place in this patient?
Because of the constant friction.
Ma'am, there's loss of the dermal appendages in burn, ma'am, which might cause
Full
delayed
thickness burns.
full
Okay,
thickness burns with loss of dermal appendages.
First of all, this burn has healed secondarily. It should not have healed like that in the first
grafted
place.
or
Right?
there was
It should have been grafted in the first
Grafted.
place.
Yes, ma'am. Yes,
It has healed secondarily with a lot of contracture. It has healed from the periphery. The center would have been an ulcer.
Yes, ma'am.
And the knee is going to go on moving. So
Yes, ma'am.
naturally, that ulcer would have never healed properly.
Yes,
It heals, breaks down, heals, breaks down. So the nidus, a perfect nidus for the formation of a cancer. Right?
Yes, ma'am.
Yes,
If this has healed well, and the ankle contracture, don't you think it is because of this itself, or is it secondary to what has happened, or do you think there is something else in the ankle? You suggested a TA lengthening and things like that. Why did it happen?
Secondary to this only.
Sorry, bone, ma'am.
So mostly, ma'am, this the ankle contracture is secondary to the marginal ulcer, ma'am.
Yes.
Extensive contracture. Yes, ma'am.
So, but now can you just do away with the contracture and do something with the with that ankle contracture, or what you said should be done now?
Ma'am, after releasing, after excision of the tumor, if this deformity gets corrected, means it is not required lengthening of the tendinochilus. If it is not there, then we have to go for a tendinochilus lengthening.
Think by like now, so many years later, do you think it can happen?
Yes, after so many years, now that the contracture has already happened, can we release it only after removing the tumor? Will it get corrected? That is what ma'am was asking.
Usually you cannot. Okay,
Yes.
you'll have to combine your other procedures, which
Yes,
you
ma'am.
said.
Yes.
Because all the other tissues down also would have gone in for contraction. There will be
Yes.
a tendency. There will be all those things which you'll have to release. That is all, sir.
Yes.
Nikhil, you have something to say, Nikhil?
After excision for team B, what flap would you like to use for reconstruction of this defect?
Sir, sir, since the patient is a child, I would like to go for a microvascular free flap reconstruction cover. If the digital vessels and neurovascular structures and joint space is exposed, then I would like to go for a flap cover. That is, I would like to go for a free flap cover, sir.
So you would like to go for the free flap cover in the same sitting, or you would like to wait for the margins to be negative?
Sir, for that, I would like to go for frozen section biopsy in the same setting. Then in the same setting, I would like to go for free flap cover, sir.
Which free flap?
Sir, I would like to go for anterolateral thigh free flap.
So you would exercise in prone position, then turn the patient to supine, then exercise, then prone, supine, then prone.
In that case, I would like to go for LD flap covers. In the lateral position, we can exercise the tumor and LD muscle with cover with along with the STSG cover. We can go.
Any easier local option you can't think of?
Sir, pedicled pedicled MSAP could be done.
Team B, Team A.
Sir, local pedicled option gastrocnemius can be used if it is not involved, sir.
So what advantage would using a gastrocnemius muscle have on the overall outcome of this patient?
Sir, there will be
Sir, a
increase in
vascularized cover would be provided by gastrocnemius flap.
In addition, during the same sitting, during the same incision, you could also release the TA, right? The TA contracture could also be taken care of.
Yes.
It is a local tissue. It is a well vascularized tissue. You would cover the entire area with a skin graft. So I think free flap is an overkill in this patient. You have in the same position, in the same prone position, same area, everything is scarred. The malignancy is, I believe, is quite grown. It might land up in amputation as well, maybe if it is not addressed adequately. So yeah, I think from my end, and see, there are two aspects in plastic surgery. One is what we can do and one is what we should do. So we can do a lot of things, but see the presentation of this patient. He has presented to us so late. So he must be having this lesion for so many years together. Medical care must be inadequate, inappropriate at where this patient is staying. So what we can do and what we should do are two different things. When discussing a patient and even in practicals, we should talk about what we should do, what we can do. Yeah. Thank you.
I think you said about lymph node metastasis. You said it doesn't metastasize. Why it doesn't metastasize?
So the lymphatics are usually damaged in these patients, sir, due to the burn injury, sir. So the metastasis is there. Yes, sir.
Now you tell me when it may metastasize.
Lymphatics damage nahi rahega in that case. So when the burn
The
is
situation may come when it may metastasize in spite of being a marginal ulcer. Team A?
The tumor
So recurrent, so recurrent margin is.
When we're giving a biopsy,
So during biopsy, so when we're taking a wedge biopsy, so it might embolize into the normal tissue and then metastasize, sir.
No, I
And
have
if it
not
is a
entered
recurrent-
into biopsy. I have not entered into biopsy at all. You
So
said biopsy. I have not said. I'm asking when a marginal ulcer may metastasize.
So if some
It's what
normal
type of
skin is
histologically what type of malignancy it is?
squamous cell carcinoma, sir. It's a squamous cell carcinoma.
So
it may metastasize if the normal skin is also involved with the burn areas.
yes. Once it has grown beyond the scar area to the normal
Normal
area,
skin. Yes, sir.
then normal lymphatics are there. It will metastasize. Now, in continuity of what Dr. Nikhil said is that if you have to do a gastrocnemius, how do you justify it? Suppose you excise it and you use a gastrocnemius muscle flap. One advantage he has said that with the same incision, you can extend it and do a TL lengthening. That's very nice. But how do you use the gastrocnemius? What is the rationality of using the gastrocnemius? How do you justify? Somebody will say free flap. He will say, I will do gastrocnemius muscle flap. How do you justify?
TL lengthening in the same sitting, sir said that.
That is done. That is done. Team A?
Sir, local
How do you justify?
Yes, sir. It will be a local pedicle flap which can be done in the same sitting with the same position and same incision, sir. and
Okay.
so a good vascularized muscle cover can be given.
But
There is not a
but you
loss
s-
of function because there are three basically muscles which are causing the same action: medial gastrocnemius, lateral gastrocnemius, and soleus. We will be just using one head of
One head of
gastrocnemius.
gastrocnemius.
So function
no,
will
you don't say just using, because it is a major functional unit. So you should not take that lightly, that it is just one unit.
so
But any other reason, you look at the lesion and think of the wide excision and the wound created. So will the gastrocnemius will reach the upper limit of the excised wound? Medial head or lateral head, will it reach there?
Sir, the one more justification point is we can reach, muscle reach will be easier when we cut the origin and also from the epimysium and also the nerve to the muscle when we ligate, the reach will be easier.
Even then it won't reach. But I agree that gastrocnemius should be used. Now you justify. It may not reach the upper limit of the excised wound, whatsoever maneuver you do. But still, I feel gastrocnemius is one of the best choice.
Myocutaneous to
No,
cover the structure,
myocutaneous is
to cover
same.
the structures over the popliteal area.
Okay, I'll answer that. See, when you excise it, the popliteal fossa, there will be exposed vital structures.
Yes, sir.
Every wound need not be covered by a flap. You divide the wound into two parts, which are graftable and which are flappable, which requires flap. Now, after excision of this lesion, the vital structures in the popliteal fossa will be exposed, for which you give a muscle flap, which will take care of it with good vascularity, and rest of the area you graft.
Yes, sir.
It is not necessary that in such cases, the whole thing has to be covered by a flap.
Yes.
That is the justification.
Yes, sir.
So, gastrocnemius is a good choice, certainly.
Yes, sir.
Sir, if you allow me, I think we have at the end of the session, sir. Any
Yes.
remarks from the senior faculty?
Yes,
Ratnam sir,
please.
you want to ask any more questions?
Dr. Bajaj, sir.
Bajaj sir, final remarks. For final remarks, I would like to request Bajaj sir.
Wait,
Sri Bajaj sir.
Ajay sir.
I think
Are you going to ask me about these questions? The only thing I can say, the questions were very nicely asked and all the cases were very good, very nicely presented, and both teams did very well. Only one thing which I want to add, very often we are talking about tangential excision, and today Nikhil asked about the history of tangential excision. I just want to put it down, it's a very blankly used word, tangential excision. When Zanjikovic started tangential excision, she was doing it for every type of burns, mostly even for superficial burns. At that time, excision of burns was done by only one person, and that is Douglas Jackson, that was full thickness burns. Douglas Jackson first time explained that this should be used for deep dermal burns. When this was started, it was said no, if the patient has growing pseudomonas. The thinking at that time was, when you are doing this tangential excision, your aim is to preserve the reticular dermis. This reticular dermis is histologically dead, but it is physiologically alive because oxygen consumption can be seen by this layer. Therefore, it was necessary at the time thought that all these areas should be fully covered, not like we are doing nowadays with oxygen. So that clarity was not there at that time. The two things happened, that Douglas Jackson started it to be done only for deep dermal burn. When they were doing this thing, the third thing was done. When you start doing it, moment you see thrombosed veins This was stopped, and then it was done in a normal excision by using your ordinary knife. The advantage was that when you're doing this thing, then the bleeding will be less. You can catch hold of the bleeders. In due course of time, when better antibiotics came up, this thing started that you went on excising, even in the case of deep burns. By deep burns, we mean full thickness burns. This is called sequential excision. When you keep on doing tangential excision, which are done for the sake of only deep dermal burn. By deep dermal burns, we mean second degree deep burn, where you have more or less whole of the plexiform dermis has gone and reticular dermis remains. It was not done for third degree burn. So when you start doing this thing for third degree burns also, then you call it sequential burn. That is simply for the history sake. Second thing I noticed with our students, they are all very nice boys, that they were not understanding what is first degree burn. First degree burn, second degree burn, and third degree burn. Very often I saw the confusing term they were using. Third degree burn means deep dermal burn, and the fourth degree burn, they call it full thickness burn. Now, when this thing was done, this is otherwise the burn. First degree burn is practically no burn. It's just like sunburn. Epidermis has got no blood supply, redness coming up. The second degree burn is the real burn which you calculate. This second degree burn and again divide into two, second degree superficial, which are going to heal by on its own, and secondary deep dermal burn, which will require excision and grafting. And that is here the tangential burns come. Third degree burn, which is full thickness burn, that should be excised with normal knife, Bart Parker's knife or whatever normal knife, so the bleeding. And in all these cases, skin graft can be taken. Now, these are just simply to clarify, where most often I just notice a little confusion coming up. Therefore, I thought again. Otherwise, everyone did a very good job to the questions they asked, and judges and everyone. And Nikhil was very good in asking the questions. The quality of questions asked was very good, and it was very satisfying to see our boys. They were doing really well. Thank you very much.